Good evening and welcome to Rest Academy. Tonight you'll journey across the entire cardiovascular system in 2 calm hours. How does the heart keep blood moving in only one direction? How do vessels quietly shape its rhythm? And what happens when this balance falters? To make this journey complete, I've prepared a free practical guide with a concise summary of tonight's lesson, waiting in the description like a map you can return to whenever needed. You will relax, you will learn, and together, let's begin. Your heart rests behind the sternum, surrounded by ribs that form a cage, yet inside this shield it remains in motion from the first week of embryonic life until the last moment of breath. The sound you notice, the steady lub-dub, arises from 4 distinct chambers, 2 atria above and 2 ventricles below. Each chamber is walled with specialized muscle called myocardium, and together they orchestrate a cycle of filling and ejection. But how is it that blood never swirls endlessly in circles? The answer lies not only in anatomy, but also in timing. The atria, thin-walled and light, serve as reservoirs. They collect blood returning from veins, oxygenated blood from pulmonary veins on the left, and deoxygenated blood from systemic veins on the right. Below them, the ventricles act as pumps. Their muscular walls contract with force, propelling blood either into the pulmonary artery toward the lungs or into the aorta toward the entire body. This division ensures that each drop of blood passes through the lungs before reaching tissues, a principle known as double circulation. Without this arrangement, oxygen delivery would be inadequate and waste removal incomplete. Consider the left ventricle. Its muscle is notably thick. This is no accident. Pumping blood upward to the brain and downward to the feet requires immense pressure, and the left ventricle shoulders that responsibility. In contrast, the right ventricle only sends blood a short distance to the lungs. Its thinner wall reflects the reduced resistance of pulmonary vessels. This asymmetry is efficient, yet it sets the stage for imbalance if either side falters. A weakened right ventricle may back blood into systemic veins, while a failing left ventricle may cause congestion in the lungs. Imagine the chambers as rooms in a house, each with doors that open one way only. These doors are valves, ensuring forward flow. When the atria contract, blood passes into ventricles through atrioventricular valves. On the left side, the mitral valve with 2 cusps resembles a curtain that swings downward. On the right, the tricuspid valve opens with 3 flaps. When ventricles contract, pressure forces these valves shut, preventing backward leakage. At the same moment, semilunar valves at the exits of ventricles open upward, releasing blood into arteries. Their crescent-shaped cusps fold tightly when pressure falls, sealing the pathway. Without these valves, circulation would be chaotic, with blood oscillating instead of advancing. Yet valves alone cannot resist high pressure. They rely on cord-like tendons, the chordae tendine, which tether them to small papillary muscles anchored in the ventricular wall. When ventricles contract, papillary muscles tense, holding the cords and preventing valves from flapping backward into atria. In this way, the valves act less like swinging doors and more like parachutes secured by strings, designed to open just enough and no further. If these cords rupture, blood may leak backward, producing murmurs that physicians detect with a stethoscope. Such sounds are signals to seek professional evaluation, as they may indicate structural compromise. One patient story illustrates the point. A young athlete developed fatigue and breathlessness out of proportion to training. Examination revealed a defective mitral valve, allowing blood to regurgitate into the left atrium during exertion. The heart compensated by enlarging, but eventually the strain became evident. Medical attention identified the issue before irreversible damage occurred. This reminds you that while anatomy is constant, individual variation and vulnerability exist. Reflect for a moment. The heart's design appears both simple and profound. 2 upper rooms, 2 lower rooms, valves that enforce direction, and cords that prevent collapse. You may picture a mill with water wheels, channels, and gates, yet instead of water, it is blood carrying oxygen and nutrients. Unlike the mill, though, your heart never rests. Each chamber must follow its precise sequence day and night. And still one question remains: how do these 4 chambers, separate in task, manage to beat not in discord but in harmony, stroke after stroke without pause? The left ventricle feels like a thick-walled fortress, while the right ventricle resembles a lighter chamber, yet both contract with perfect rhythm to sustain life. You may wonder why nature built such asymmetry in the heart's design. The explanation rests in the distances blood must travel and the pressures required to maintain forward flow. The left ventricle pushes blood into the aorta, a vessel that immediately branches into arteries leading toward every organ. These arteries narrow into arterioles and then into capillaries, where exchange with tissues takes place. Because resistance increases with each branching, the ventricle must generate high pressure to ensure that oxygen reaches distant sites such as toes, kidneys, or brain. Hence, its walls are thick, composed of densely packed cardiac muscle fibers. By contrast, the right ventricle directs blood only to the lungs. Pulmonary arteries branch into capillaries spread across delicate alveoli, where oxygen enters and carbon dioxide leaves. This distance is short, and pulmonary vessels offer less resistance. Thus, the right ventricle can perform its role with a thinner wall, conserving energy. Visualize two water pumps. One pushes water through a garden hose across the yard, demanding force. The other pushes water into a nearby basin, requiring far less strength. Both are necessary, but their structures differ according to function. The same principle applies here. Ventricles are matched to their loads. This asymmetry reveals the elegance of cardiovascular engineering, yet also its vulnerabilities. When blood pressure in the body rises chronically, the left ventricle thickens further, adapting at first but eventually struggling. Conversely, when lung resistance increases due to chronic disease, the right ventricle enlarges in an attempt to keep up, a situation often termed cor pulmonale. Within these muscular walls, fibers contract in a spiral arrangement rather than in parallel lines. This orientation allows the ventricles to twist as they squeeze, like wringing out a cloth, which enhances the efficiency of ejection. The twisting motion is subtle but critical, ensuring maximal blood delivery with each beat. Without this spiral design, the heart would consume more energy for less effect. Consider the clinical picture of an older man with long-standing high blood pressure. His left ventricle thickens, its chamber narrowing over time. At first, the extra muscle maintains adequate circulation, but with years of strain, the muscle stiffens, resisting proper filling during relaxation. He notices shortness of breath when climbing stairs. Here you see the cost of chronic overload, adaptation giving way to limitation. It serves as a reminder that balance in systemic pressures is as vital as the pump itself. Now reflect, each ventricle, though different in form, contributes to the single goal of circulation, continuous delivery of oxygen, and removal of waste. The left side embodies endurance and force, the right side agility and economy. Together they form a dual system, and yet a new question arises. If their strengths differ so markedly, what prevents them from competing or falling out of sequence? When you hear the steady beat of your chest, you may think only of muscle contracting, but that sound is shaped by valves, delicate structures that enforce direction in a system driven by pressure. These valves act as guardians of flow, ensuring blood moves forward without retreat. Between atria and ventricles lie the atrioventricular valves. On the right side sits the tricuspid valve with 3 flaps or cusps that resemble sails. On the left side rests the mitral valve, named for its resemblance to a bishop's mitre, with 2 cusps. When atria contract, these valves open downward, allowing blood to fill ventricles. As pressure rises in ventricles during contraction, the valves swing shut, producing the first heart sound. Their closure prevents retrograde flow into atria, a crucial safeguard against inefficiency. At the exits of ventricles are the semilunar valves, named for their half-moon-shaped cusps. On the left, the aortic valve controls blood, leaving for systemic circulation. On the right, the pulmonary valve governs flow toward the lungs. These open when ventricular pressure exceeds arterial pressure and close when pressure falls, yielding the second heart sound. With every beat, they operate silently except for the distinct vibrations that together create the rhythm physicians recognize with a stethoscope. Yet valves are not passive flaps. They are restrained by supporting cords called chordae tendineae. These cords connect the free edges of atrioventricular valves to papillary muscles within the ventricles. When ventricles contract, papillary muscles tighten, preventing valves from bulging back into atria. Without this mechanism, the high pressures generated could force valves backward, causing regurgitation. Imagine parachutes held by ropes. Without tension, the fabric would invert and fail. The same principle secures the valves of your heart. Still, the system is not immune to weakness. In some individuals, valve leaflets thicken or calcify with age, narrowing the passage and forcing the heart to work harder. Others may experience valve prolapse, in which a leaflet bows into the atrium, producing a distinctive murmur. These sounds are not mere curiosities. They may signal a condition requiring professional attention to prevent progression to heart failure. Picture a student who notices palpitations during quiet study. A routine examination reveals a mid-systolic click, later confirmed as mitral valve prolapse. For many, this remains benign, yet in others it can predispose to complications. The lesson is not alarm, but awareness. Valves, though small, are critical sentinels whose structure and function deserve respect. Consider also the metaphor of doors in a one-way corridor. Each opens only forward, guiding you to the next room, and none allow retreat. In the heart, this corridor loops endlessly, yet the direction remains constant because of these gates. Without them, circulation would resemble a crowded hall with people moving against one another, chaotic and ineffective. As you reflect, recognize the paradox. Valves are thin, flexible, almost fragile, yet they maintain order in a high-pressure environment. Their cooperation with muscle and cords transforms what could be turbulence into flow. But this raises a deeper question. If valves control direction, what ensures that both sides of the heart send blood into their separate circuits without confusion or mixing? Two great streams of circulation exist in your body, flowing side by side yet never blending within the heart itself. One delivers blood to the lungs for gas exchange, and the other propels blood to every tissue. These twin loops, pulmonary and systemic, define the principle of double circulation. But how do they remain separate and coordinated? The pulmonary circuit begins in the right ventricle. When it contracts, blood is ejected through the pulmonary valve into the pulmonary artery, which branches toward the lungs. There, capillaries surround tiny air sacs called alveoli. Oxygen diffuses into blood, while carbon dioxide leaves. This circuit is short and low in pressure, protecting delicate lung tissue from damage. The freshly oxygenated blood then returns via pulmonary veins to the left atrium, ready to enter systemic circulation. The systemic circuit begins in the left ventricle. With every contraction, blood is forced through the aortic valve into the aorta, the largest artery in the body. From there, branching vessels carry blood upward to the brain and downward to limbs and organs. In distant capillaries, oxygen and nutrients exit while waste products enter. Veins collect the used blood, bringing it back toward the right atrium through the superior and inferior venae cavae. The loop is complete and the cycle begins again. The separation of these circuits is critical. Oxygen-rich blood must not mix with oxygen-poor blood inside the heart, or efficiency would collapse. This separation is enforced by the septum, a wall of tissue dividing right and left sides. It ensures that blood destined for the lungs stays distinct from blood bound for tissues. Only in early fetal life does a small opening allow mixing, a necessity before birth when the lungs are not yet functional. Normally this opening closes after birth, sealing the two circuits apart. Think of two rivers running parallel, one delivering fresh water, the other carrying used water back for cleansing. If they merged upstream, contamination would follow, and the cycle would fail. Likewise, your two circulations must remain distinct, each fulfilling its role before handing blood back to the other. Disruption of this separation can have serious consequences. Some infants are born with congenital heart defects that allow mixing, such as a hole in the septum. In such cases, oxygen levels in systemic blood may fall, leading to cyanosis, a bluish discoloration of the skin. While advances in medicine allow many of these defects to be corrected surgically, their presence reminds us of the precision required to sustain double circulation. Consider the example of a young nurse who noticed bluish lips in a newborn during routine care. Further tests revealed a ventricular septal defect where blood from the left ventricle leaked into the right. Prompt medical attention ensured the child received proper management and eventual repair. Such stories underline the vigilance required when the architecture of circulation is altered. Reflect on this. Your heart is not a single pump but two pumps placed side by side, each with its own destination and pressure system, yet they beat together as one. This unity and division raises a further question. what keeps blood moving smoothly within each circuit without turbulence or clotting, despite the constant pressure changes. When blood moves through the heart's interior, it glides against a lining so smooth that turbulence rarely occurs. This lining is the endocardium, a thin sheet of specialized cells that covers every chamber and valve. Though barely visible to the eye, it performs an essential function. It creates a surface where blood can flow without friction or clot formation. The endocardium is made of squamous endothelial cells, flattened like tiles laid edge to edge. Their arrangement is not random. It minimizes resistance, much like polished stone guiding water in a fountain. These cells also release chemical signals that prevent unnecessary clotting. One of their products is nitric oxide, a molecule that relaxes nearby vessels and discourages platelets from sticking. Without this regulation, each heartbeat could trigger small clots, gradually obstructing circulation. Imagine a canal lined with moss-free stone. Water runs clear, its movement uninterrupted. If the stone is roughened, water swirls, debris collects, and blockages appear. In the heart, the endocardium ensures the canal remains polished and free of obstructions. Its importance becomes evident when disease alters it. In conditions such as infective endocarditis, bacteria attach to the lining, creating rough patches where clots and growths form. These may detach and travel, causing emboli in distant arteries. Thus, a tissue measured in micrometers guards the integrity of the entire circulation. This inner lining also hosts Purkinje fibers in the ventricles, specialized conduction pathways that transmit electrical impulses. These fibers ensure that muscle contraction spreads quickly and evenly, coordinating the forceful squeeze that ejects blood. The endocardium is therefore not merely a passive lining, but an active participant in both mechanical and electrical harmony. Consider the case of a middle-aged woman who developed a fever after dental surgery. Days later, she noticed sudden weakness on one side of her body. Investigation revealed a stroke caused by emboli from bacterial growths on her endocardium. Her story demonstrates how disturbance of this delicate layer can send consequences far beyond the heart itself. Professional care in such scenarios is essential, as infection in the endocardium rarely resolves on its own. Yet in health, this lining is invisible to you. You do not feel its presence, and you cannot sense its signals. Its quiet function allows each chamber to act as a frictionless reservoir and pump. Reflection on its subtlety highlights a truth. Sometimes the smallest structures bear the greatest responsibility. Now pause on this thought. If the inner surface ensures smooth blood flow, what lies beneath it that actually generates the power of each beat? And how does that muscular layer resist fatigue across a lifetime? Beneath the smooth endocardium lies the true engine of the heart, the myocardium. This muscular layer, composed of specialized cardiac muscle cells, provides the contractile force that propels blood forward. Unlike skeletal muscle, which responds to voluntary command, or smooth muscle, which sustains tension slowly, cardiac muscle is uniquely adapted for rhythmic, lifelong work. Its fibers shorten and relax in cycles that repeat billions of times without pause. The question is, how does this tissue resist fatigue where other muscles would fail? Cardiac muscle fibers are striated, meaning they show alternating light and dark bands under a microscope, much like skeletal muscle. Yet they differ in key ways. The fibers branch and connect at junctions called intercalated discs. Within these discs, gap junctions allow ions to flow directly from one cell to another, ensuring electrical impulses spread rapidly. This makes the myocardium a functional syncytium, many cells acting as if they were one. The benefit is clear. When one cell is excited, its neighbors follow instantly, producing a coordinated contraction. The myocardium also contains abundant mitochondria, the cell's powerhouses. These organelles generate continuous energy in the form of adenosine triphosphate, ATP. A skeletal muscle fiber might fatigue after intense work, but cardiac muscle rarely does because of its dense mitochondrial supply and steady access to oxygen-rich blood from the coronary arteries. Even so, when coronary arteries narrow or block, oxygen delivery falters. Without sufficient oxygen, myocardium weakens and tissue death can occur, leading to what is clinically termed myocardial infarction. Picture the myocardium as a team of rowers pulling in unison. If one rower tires, the others maintain the pace and signals spread down the line to coordinate strokes. The oars cut water together, propelling the vessel smoothly forward. In the heart, intercalated discs are the shouted commands, mitochondria, the food-sustaining energy, and coronary circulation, the river supplying fresh resources. Without these, the rhythm falters. Adaptation occurs when workload changes. In athletes, the myocardium may thicken slightly, allowing stronger contractions to handle increased demands. This physiologic hypertrophy differs from the maladaptive thickening caused by chronic hypertension, where walls stiffen and chambers struggle to fill. Both look similar at first glance, but one reflects health and the other disease. Consider a patient who develops chest pain when climbing hills. Tests reveal narrowed coronary arteries. The myocardium, deprived of oxygen during exertion, signals distress through pain known as angina. This serves as a warning to seek medical evaluation before more severe injury occurs. Such examples show the balance between energy supply and demand that the myocardium must maintain. Reflect on the marvel of this tissue. It contracts tirelessly from before birth to the end of life, each cell contributing to a collective rhythm. Unlike skeletal muscle, it never rests for hours. Unlike smooth muscle, it generates rapid and powerful force. Its design is compromise perfected. Yet this raises a deeper question. If the myocardium drives contraction, what prevents the heart from expanding without limit under pressure, and how is its size restrained within the chest? Around the beating heart lies a silent guardian, the pericardium. This structure is often described simply as a fibrous sac, but its role is richer than a mere wrapper. It anchors, protects, and restrains, ensuring that the heart beats in freedom yet never exceeds its boundaries. Without it, every surge of blood might stretch the chambers dangerously, and the rhythm of circulation would lose stability. The pericardium has two main layers. The outer layer, the fibrous pericardium, is tough and inelastic. It blends with surrounding tissues, attaching to the diaphragm below and to the great vessels above, fixing the heart within the mediastinum. Its stiffness prevents overexpansion, acting like a firm case around a delicate instrument. The inner layer, the serous pericardium, is thinner and more refined. It folds back on itself to form two parts, the parietal layer lining the fibrous sac and the visceral layer, also known as the epicardium, which lies directly upon the heart muscle. Between these lies the pericardial cavity, containing a thin film of fluid that reduces friction as the heart beats. Think of a violin resting in its case. The case prevents crushing, keeps the instrument in place, and allows it to travel unharmed. The violin can vibrate freely when played, yet it is never left unguarded. In the same way, the heart expands and contracts inside the pericardial sac, cushioned by fluid and restrained by fibrous tissue. Each movement glides smoothly, avoiding the irritation that bare surfaces might cause. The pericardium also serves as a barrier to infection. Structures within the chest may harbor bacteria or inflammatory processes, yet the fibrous layer offers protection, limiting spread into the heart. When infection does reach it, however, inflammation of the sac called pericarditis produces sharp chest pain that changes with position. Physicians can detect a characteristic friction rub like leather creaking when listening with a stethoscope. In severe cases, fluid may accumulate excessively, compressing the heart and impairing its filling, a condition known as cardiac tamponade. This illustrates how the same structure that protects can also, when diseased, endanger. Consider the story of a young physician who noticed that a patient with trauma had falling blood pressure and distended neck veins. An ultrasound revealed fluid building up within the pericardial sac. Urgent drainage was required to relieve the pressure, allowing the heart to expand once again. Here the pericardium, normally a protector, had become a trap. It reminds you that every safeguard has limits. In everyday health, you never sense the pericardium. Its fluid cushion prevents awareness of friction, and its fibrous shell remains silent. Yet its presence is constant, keeping each beat within safe dimensions. Reflect for a moment on this balance, freedom of movement within firm boundaries. It is a principle echoed in many aspects of physiology and life itself. But if the pericardium defines the outer boundary of the heart, what divides the inner chambers, keeping right and left streams of circulation from mingling within the core of the organ, At the very center of your heart lies a boundary wall known as the septum. It is not a flat partition, but a thick muscular divider that separates the right and left sides, ensuring that oxygen-poor blood remains distinct from oxygen-rich blood. Without this barrier, the elegant dual-circuit design of circulation would collapse into disorder. The septum serves both structural and functional purposes, forming the strong midline that keeps the two pumps working side by side, yet independently. The septum has several regions. The interatrial septum lies between the two atria, thin and membranous. The interventricular septum, much thicker, divides the ventricles. Its muscular portion forms the bulk of the partition, while a small membranous part near the top closes off the last gap. During development in the womb, this partition is not fully sealed. A small opening called the foramen ovale allows blood to bypass the lungs, which are not yet functional. At birth, when the newborn takes the first breath, pressures shift, and the flap of tissue seals the hole, leaving a depression called the fossa ovalis. If this closure fails, the result is a patent foramen ovale, a condition that may allow blood to slip from one atrium to another. Many live with it unknowingly, but in some, it increases the risk of small clots traveling to the brain. The interventricular septum does more than divide space. It houses part of the heart's conduction system. The bundle of His, a cable of specialized fibers, runs down this wall, splitting into right and left bundle branches. These fibers carry the electrical impulse from the atrioventricular node toward the ventricles, ensuring that both chambers contract together. Thus, the septum is not only an anatomical wall, but also an electrical highway. Any damage to this region, such as from a heart attack affecting the septal artery, can disrupt conduction, producing blocks that alter the rhythm and coordination of beats. Imagine a dam separating two reservoirs, one filled with fresh water and the other with water already used for irrigation. The dam not only prevents mixing, but also houses turbines that generate power. If the wall weakens, the waters blend, and the turbines falter. The heart septum plays an equally dual role, dividing streams and carrying signals. Clinicians often listen for murmurs along the septal region. A ventricular septal defect, or VSD, creates a hole through which high-pressure blood from the left ventricle rushes into the right. The result is a harsh sound audible with a stethoscope. Small defects may close spontaneously, but larger ones require attention to prevent overload of the lungs and failure of the right ventricle. Here, a few millimeters of tissue mean the difference between balanced flow and dangerous turbulence. Consider a child brought to clinic with frequent respiratory infections and poor weight gain. Examination reveals a murmur, later confirmed as a VSD. With proper care, surgical closure restores the normal separation, and the child thrives. This story shows how the septum, though invisible to us, can define the course of health or illness. Beyond its structural and electrical roles, the septum also reflects adaptation. In cases of pulmonary hypertension, the high pressure on the right side may push the septum leftward, distorting the left ventricle and impairing its filling. Conversely, in systemic hypertension, the left ventricle thickens and the septum bulges rightward. These shifts remind you that the wall is not fixed like stone, but a living tissue responsive to pressure changes. Pause and reflect. The septum embodies separation, coordination, and adaptation all at once. It divides two pumps, yet connects them electrically, maintains purity of flow, yet shifts when pressure demands it. In this paradox, you see the heart's resilience, but also its fragility. And so another question arises. If the septum prevents mixing, how do we recognize the difference between blood on each side? What colors, what qualities distinguish oxygen-rich blood from oxygen-poor blood as it moves through the vessels? When you look at diagrams of circulation, you often see two colors, bright red for oxygenated blood and deep blue for deoxygenated blood. This color code is a teaching convention, yet it reveals a truth about function while also hiding subtleties. In reality, blood is never truly blue, it is always some shade of red. The difference lies in how much oxygen is bound to hemoglobin, the protein within red blood cells that carries gases. Understanding these shades helps explain how blood shifts between lungs and tissues and why clinicians pay close attention to oxygenation levels. Hemoglobin consists of 4 subunits, each capable of binding 1 molecule of oxygen. When fully saturated, it imparts a bright scarlet color to blood. As oxygen leaves in tissues, hemoglobin becomes partially deoxygenated. turning the blood a darker crimson. The blue, often shown in illustrations, represents this state, though it is still red when seen directly. Veins beneath the skin may appear bluish, not because blood itself is blue, but because of how light penetrates and scatters through tissue. Shorter wavelengths reflect back more readily, creating the illusion of blue vessels. The contrast between oxygen-rich and oxygen-poor blood is crucial for physiology. Oxygenated blood leaving the lungs must remain separate from deoxygenated blood returning from tissues. In the left side of the heart, oxygen saturation usually approaches near complete levels. This ensures that every organ receives a fresh supply. On the right side, venous blood carries carbon dioxide and metabolic waste, ready to be exchanged in the lungs. If mixing occurs, such as in congenital defects or severe heart failure, oxygen delivery falls, producing cyanosis. This manifests as a bluish tinge to lips, fingers, or skin, a signal that tissues are not receiving enough oxygen. Think of two rivers again, one carrying clear water freshly melted from mountain ice, the other carrying darker, silt-laden water after irrigating fields. Both are water, yet their qualities differ. In the body, both streams are blood, yet their oxygen content separates them into distinct flows with distinct purposes. The distinction is not merely visual. Oxygenated blood carries a higher pH, meaning it is less acidic, while venous blood accumulates hydrogen ions and carbon dioxide, lowering its pH slightly. These chemical changes influence how hemoglobin binds oxygen. In tissues where carbon dioxide is high, hemoglobin releases oxygen more readily, a phenomenon known as the Bohr effect. This ensures oxygen is delivered precisely where it is needed most, areas of greatest activity. Consider the example of a young climber ascending to high altitude. At sea level, oxygen saturations are near complete, but at altitude, the reduced oxygen pressure means hemoglobin cannot bind fully. The climber notices fatigue, breathlessness, and sometimes a bluish hue to lips. This illustrates how color, chemistry, and physiology intertwine, turning a diagram's two shades into a living spectrum. Clinicians monitor oxygen saturation with a pulse oximeter, a device clipped to a finger that shines light through the tissue. By analyzing how light is absorbed at different wavelengths, it estimates the proportion of hemoglobin bound to oxygen. Normal values approach 96 to 100% at rest. Lower values suggest impaired lung function, heart failure, or circulation problems. While the device is simple, it translates the invisible chemistry of blood into a visible number, guiding care. Reflect on this. The dual shades of blood symbolize more than pigment. They embody the ceaseless cycle of delivery and return. Bright red signals abundance, dark red signals need, and together they define circulation's rhythm. But this distinction raises the next puzzle. If arteries and veins carry such different streams, how do we define them by color, by content, or by the direction in which they move? At first glance, you might assume that arteries are defined by the kind of blood they carry, red, oxygen-rich blood. Yet the truth is more precise. Arteries are vessels that carry blood away from the heart, regardless of its oxygen content. This definition holds even when the blood they carry is low in oxygen, as is the case with pulmonary arteries. By focusing on direction rather than content, medicine avoids confusion and maintains clarity across diverse situations. Arteries possess distinctive features. Their walls are thick and elastic, built from 3 layers. The tunica intima lines the lumen with endothelium, providing a smooth surface. The tunica media forms the muscular middle, rich in elastic fibers that allow arteries to stretch during systole and recoil during diastole. The tunica adventitia anchors the vessel, blending with surrounding tissue. This layered construction ensures that arteries withstand high pressures generated by ventricular contraction. The aorta exemplifies this design. With each beat of the left ventricle, blood surges into it, expanding its elastic wall. As the ventricle relaxes, the wall recoils, propelling blood forward even when the pump itself rests. This elastic rebound smooths flow, transforming a pulsatile surge into a continuous stream through smaller arteries. In this way, the aorta acts as a reservoir of energy, conserving the force of each heartbeat and releasing it gradually. Yet not all arteries are alike. Large elastic arteries, such as the aorta and pulmonary trunk, emphasize stretch and recoil. Medium muscular arteries, such as those supplying limbs, contain more smooth muscle, allowing them to regulate diameter and distribute blood according to demand. Arterioles, the smallest branches, serve as resistance vessels. Their constriction or dilation determines systemic blood pressure and directs flow into capillary networks. These subtle adjustments are under constant influence from nerves, hormones, and local chemical signals. Imagine a system of highways. The aorta is the main interstate, broad and resilient, carrying heavy traffic. Muscular arteries are regional roads, directing flow towards specific cities. Arterioles are narrow streets where signals control who enters and when. Together they form a hierarchy that ensures delivery from central source to final destination. The pulmonary artery illustrates why definition matters. Though it carries deoxygenated blood, it is still an artery because it moves blood away from the heart. This apparent exception often puzzles beginners until the principle of direction is understood. Similarly, the umbilical arteries of a fetus carry deoxygenated blood back toward the placenta, not away from it. These examples highlight why clarity in terminology prevents misinterpretation. Clinical practice underscores the importance of arteries' resilience. When arterial walls weaken, they may bulge outward, forming aneurysms. Silent at first, these expansions risk rupture, which can be catastrophic. Alternatively, when arteries stiffen with age or disease, their capacity to absorb pressure falls, contributing to hypertension. A patient with hardened arteries may develop elevated systolic pressures, straining the left ventricle over time. Professional evaluation is required when symptoms such as sudden severe chest or abdominal pain arise, for they may signal arterial compromise. Reflect on this. Arteries are not defined by color or oxygen, but by their role as conduits of outward flow. They bear the first impact of each contraction and distribute lifeblood with precision. Still, if arteries are the outbound routes of circulation, what of the returning roads? How do veins differ in form and purpose, and why do they sometimes carry blood rich in oxygen instead of poor? Veins return blood to the heart, completing the circulation that arteries begin. Unlike arteries, which confront high pressure at the moment of ejection, veins operate in a quieter, lower pressure environment. Yet their role is no less vital. They serve as reservoirs, holding the majority of the body's blood volume at any given time, and they act as steady conduits guiding blood back toward the atria. To appreciate their function, you must look not only at their structure, but also at their surprising exceptions. The general rule is that veins carry blood low in oxygen, collected from tissues after exchange. This blood flows into the right atrium via the superior and inferior venae cavae. Yet in the pulmonary veins, the opposite occurs. They carry freshly oxygenated blood from the lungs into the left atrium. Despite transporting bright red blood, they remain veins because their direction of flow is toward the heart. Thus, just as pulmonary arteries challenge the assumption that arteries always carry oxygen-rich blood, pulmonary veins challenge the assumption that veins always carry oxygen-poor blood. Structurally, veins differ significantly from arteries. Their walls are thinner, with less smooth muscle and elastic tissue. The pressure within them is low, so they do not need the robust reinforcement of arterial walls. Instead, they rely on surrounding skeletal muscles and one-way valves to maintain direction. These valves, folds of endothelium, prevent backflow. They are particularly important in the legs, where blood must ascend against gravity. With each step, contraction of calf muscles squeezes veins, pushing blood upward. The valves then close to prevent it from falling back. This system, known as the skeletal muscle pump, transforms simple movement into a force that sustains circulation. Envision a series of locks in a canal. Boats ascend step by step, held in place by gates that prevent retreat. Veins operate with similar gates, ensuring that blood climbs steadily back toward the chest. Without these valves, blood would stagnate in the lower limbs, causing swelling and discomfort. Varicose veins, for example, arise when valves weaken and fail, allowing blood to pool. The bulging, twisted vessels visible beneath the skin are a reminder of the importance of structures often unnoticed when healthy. The capacity of veins to act as reservoirs is another distinctive feature. Up to 2/3 of the body's blood volume resides in the venous system at rest. This reserve can be mobilized when needed. During exercise or stress, sympathetic nerve signals cause venous walls to constrict slightly, pushing more blood toward the heart and increasing cardiac output. The system adapts fluidly, matching supply with demand. It is as though a reservoir opens its gates during times of need, ensuring steady flow downstream. Yet low venous pressure presents challenges. Blood returning from the feet must ascend against gravity, and from the abdominal organs it must traverse the portal circulation before reaching the heart. The thoracic pump assists in this effort. With each breath, pressure changes in the chest cavity draw blood upward, while abdominal pressure helps squeeze it from below. Breathing thus becomes more than gas exchange. It actively contributes to venous return. In deep inspiration, the negative pressure in the chest acts like a suction, easing blood flow into the right atrium. The liver plays a special role in venous circulation through the hepatic portal system. Nutrient-rich blood from the intestines does not return directly to the heart. Instead, it flows into the portal vein and through the liver, where substances are processed, detoxified, and stored. Only then does the blood join systemic veins and travel to the right atrium. This detour ensures that glucose, amino acids, and toxins are regulated before reaching the wider circulation. It is a reminder that not all venous pathways are straightforward. Some serve as checkpoints in the body's internal economy. Clinical examples illustrate the vulnerabilities of veins. Deep vein thrombosis, or DVT, occurs when blood clots form in deep veins, often of the legs. Immobility during long travel or illness slows venous return, predisposing to clot formation. If such a clot breaks free, it can lodge in the lungs as a pulmonary embolism, obstructing blood flow and endangering life. Warning signs may include swelling, pain, or sudden shortness of breath, signals to seek medical evaluation. Here, the low-pressure, reservoir nature of veins becomes a double-edged sword, offering capacity but risking stagnation. Contrast this with another patient scenario, an elderly man with chronic varicose veins who develops ulcers near his ankles. Poor venous return leads to chronic pooling, increased pressure, and tissue damage. These wounds heal slowly and require professional care. His condition demonstrates how venous dysfunction, while often silent for years, can culminate in lasting complications. Reflect on the broader metaphor. If arteries are highways radiating from a city center, veins are the return roads, some wide, some winding, but all converging back toward the core. Their valves are the checkpoints, their reservoirs the parking lots where vehicles pause before re-entering the main routes. Together with arteries, they form the closed circuit of life, each dependent on the other. The beauty of venous function lies in its adaptability. With little pressure of its own, it borrows from surrounding muscles, from breathing, from reserves within its walls. It accepts blood from everywhere, brain, gut, limbs, and channels, it calmly home. Yet the calmness conceals critical dependence, for without efficient return, even the strongest ventricle would eventually falter, pumping into emptiness. As you contemplate veins, one question naturally emerges. If arteries push blood forward with pressure and veins rely on valves and pumps to bring it back, how do the atria and ventricles coordinate these flows so that filling and ejection occur in perfect sequence, never colliding, never in chaos? At first it may seem astonishing that the four chambers of your heart, each with different thickness, pressures, and tasks, can work together without confusion. Atria fill while ventricles rest, ventricles contract while atria prepare for the next cycle, and through this alternation blood moves forward in perfect sequence. The coordination arises from a finely tuned rhythm known as the cardiac cycle, and every heartbeat is its performance. The cardiac cycle has two main phases: systole, when muscle contracts and blood is ejected, and diastole, when muscle relaxes and chambers fill. Yet within this simple pattern lies precise choreography. During late diastole, both atria and ventricles are relaxed. Blood flows passively from veins into atria and down into ventricles through open atrioventricular valves. This passive filling accounts for most of the ventricular volume. Just before systole begins, the atria contract, adding a final push that tops off ventricular filling. This event, known as the atrial kick, contributes about a fifth of ventricular volume at rest, more during exercise. With that, the stage is set for ejection. When systole begins, ventricular pressure rises sharply. The atrioventricular valves snap shut, producing the first heart sound, while semilunar valves remain closed. For a brief moment, all valves are shut. This is the isovolumetric contraction phase where pressure builds without volume change. Once ventricular pressure exceeds arterial pressure, semilunar valves swing open and blood is ejected into the aorta and pulmonary artery. After contraction, ventricles begin to relax. As pressure falls, semilunar valves close, producing the second heart sound. Another brief phase of isovolumetric relaxation follows, with all valves closed until atrial pressure surpasses ventricular pressure. Then atrioventricular valves open again and filling resumes. The cycle continues endlessly, beat after beat. The synchrony between atria and ventricles relies on timing. Atria contract just before ventricles, ensuring that ventricles begin systole already filled. If both contracted together, filling would be incomplete and ejection inefficient. Electrical conduction dictates this sequence, with signals traveling from pacemaker cells in the sinoatrial node through specialized pathways to coordinate contractions. The result is a wave of depolarization sweeping across chambers in order. Guiding muscle like a conductor's baton directs an orchestra. Visualize a relay race. The first runner, the atrium, sprints a short distance and hands the baton of blood to the ventricle. The second runner, the ventricle, covers the longer distance, propelling blood into arteries. If the baton is dropped or the timing is off, the race falters. The cardiac cycle is a race repeated every second, flawlessly executed through coordination rather than brute force. Clinical conditions reveal what happens when synchrony breaks. In atrial fibrillation, the atria quiver instead of contracting effectively. The atrial kick is lost, reducing ventricular filling, especially in older individuals whose ventricles rely more heavily on this final boost. Patients may feel palpitations, fatigue, or shortness of breath. The irregular rhythm increases risk of clot formation in atria, which may dislodge and cause stroke. Here, the absence of synchrony between atria and ventricles demonstrates how essential the sequence is for health. Another scenario involves atrioventricular block, where conduction between atria and ventricles is impaired. Depending on severity, ventricles may beat independently at a slower pace. This disconnect leads to fatigue, dizziness, or fainting. A pacemaker may be required to restore coordination. The heart's reliance on conduction highlights that electrical order underlies mechanical order. Without signal, muscle loses harmony. The cardiac cycle also adapts to demand. At rest, diastole occupies more time, allowing full filling. During exercise, diastole shortens but ventricles compensate by filling more rapidly, aided by stronger atrial contraction and enhanced venous return. Heart rate increases, stroke volume rises, and cardiac output may multiply several times to meet tissue needs. The synchrony remains intact despite accelerated tempo, like an orchestra playing allegro with precision intact. Consider the case of a young athlete during a marathon. As pace intensifies, her heart rate doubles, and yet blood continues to move smoothly through the cycle. Atria contract more forcefully, ventricles fill swiftly, and ejection volumes remain high. The same cycle that maintains quiet rest adapts seamlessly to extreme exertion. Without such flexibility, endurance would falter quickly. Yet synchrony can fail not only through disease but also through external strain. Severe electrolyte imbalances, such as potassium disturbances, disrupt conduction, altering the timing of contraction. Drugs or toxins may interfere with ion channels, causing dangerous arrhythmias. These situations underscore how delicate the balance is and how strongly it depends on cellular and molecular precision. Another perspective comes from fetal life. Before birth, circulation differs. Blood bypasses the lungs through the foramen ovale and ductus arteriosus. The sequence of atrial and ventricular contractions still occurs, but pathways diverge. At birth, when the newborn takes a first breath, pressures shift, fetal shunts close, and the standard cycle begins. This transition illustrates the heart's remarkable adaptability, shifting from intrauterine to extrauterine life in a matter of moments. Think also about sleep. During deep rest, heart rate slows, diastole lengthens, and ventricles fill more fully. The body's oxygen demand is reduced, so the cycle adapts by prioritizing efficiency over speed. In contrast, during a stressful event, sympathetic activation accelerates heart rate and strengthens contractions, shifting balance toward forceful systole. These changes occur without conscious effort, guided by autonomic control, yet they reflect the plasticity of synchronization between atria and ventricles. To tie these threads together, imagine the heart as a four-room house with 2 upstairs atria and 2 downstairs ventricles. Upstairs residents hand buckets of water to those downstairs, who then throw them out through windows into great rivers. The handoff must occur in sequence, upstairs first, then downstairs, otherwise the house floods or fails. Valves act as doors, conduction as the schedule, and rhythm as the metronome. When order is preserved, the system sustains itself indefinitely. Reflect on this: your heart never rests from its coordination, and you never need to instruct it. It cycles naturally, maintaining synchrony across chambers, adapting tempo to your needs. And yet another question remains open. If coordination depends on electrical signals to spread in exact order, what mechanism inside the heart ensures those signals arise and travel with such consistency, beat after beat, without external command? The harmony of your heartbeat depends on a hidden wiring system, a network of specialized cells that carry electrical impulses with extraordinary precision. This is the cardiac conduction system, a collection of nodes and fibers distinct from ordinary muscle, yet embedded within the myocardium. Without it, the chambers would contract randomly, wasting effort and energy. With it, each contraction is ordered, beginning in the atria, spreading through the ventricles, and ending in coordinated ejection of blood. At its core, the conduction system ensures that depolarization, the electrical spark that initiates contraction, moves in the correct sequence. Depolarization begins in one area, spreads rapidly, and is delayed strategically in others, producing a cascade rather than a collision. The main components of this system are the sinoatrial node, the atrioventricular node, the bundle of His, the bundle branches, and the Purkinje fibers. Each plays a specific role, and together they function like a series of relay stations guiding a signal across a complex landscape. The sinoatrial node, or SA node, lies high in the right atrium near the opening of the superior vena cava. It is the natural pacemaker of the heart, initiating impulses about once every second at rest, faster during activity. Its cells possess spontaneous depolarization due to ion channel dynamics. Slow leakage of sodium and calcium ions gradually raises the membrane potential until threshold is reached. Then a burst of depolarization occurs, triggering contraction in surrounding atrial muscle. Unlike skeletal muscle, which requires nerve input to contract, these pacemaker cells are autonomous, endowed with intrinsic rhythm. From the SA node, impulses spread across both atria, causing atrial muscle fibers to contract almost simultaneously. The wave of depolarization moves like ripples from a stone dropped in water, quickly reaching the atrioventricular node, or AV node, located near the junction of atria and ventricles. Here conduction slows deliberately. This delay, lasting a fraction of a second, ensures that atria finish contracting and ventricles complete filling before ventricular systole begins. Without this pause, the sequence would collapse, with atria and ventricles contracting together. Beyond the AV node, the bundle of His carries impulses into the interventricular septum. This bundle soon divides into right and left branches, each descending along the septum toward its respective ventricle. The right bundle directs impulses to the right ventricle, while the left bundle, sometimes divided further into anterior and posterior fascicles, spreads into the left ventricle. These bundles ensure that depolarization moves downward toward the apex of the heart first. The logic of this design is striking. Ventricles contract from the bottom upward, squeezing blood toward the exits at the top, where semilunar valves and arteries await. Purkinje fibers, the final relay, fan out through ventricular walls. They are larger than ordinary cardiac fibers and conduct impulses at remarkable speed, ensuring near simultaneous contraction of ventricular muscle. This rapid spread creates the powerful coordinated squeeze that ejects blood efficiently. If you imagine a stadium crowd performing a wave, the Purkinje fibers are the organizers who ensure that the motion starts at the right end, sweeps across rapidly, and finishes in perfect timing. This electrical system is not immune to failure. Blockages can occur in bundle branches, slowing conduction on one side and creating dyssynchrony. Ventricles then contract unevenly, reducing efficiency. In severe cases, artificial devices called pacemakers or defibrillators are implanted to restore order. Arrhythmias arise when impulses originate in abnormal sites, bypassing the SA node. Premature beats, atrial flutter, or ventricular tachycardia are all manifestations of electrical disarray. Each reminds us how dependent mechanical function is on electrical order. A patient's story highlights this point. An older man presents with dizziness and fainting. Electrocardiography reveals complete heart block. Impulses from the atria fail to reach ventricles. His atria beat normally, but ventricles adopt their own slow rhythm, insufficient for proper circulation. Implantation of a pacemaker restores synchrony, with artificial impulses taking over the role of conduction where natural fibers have failed. This intervention demonstrates how understanding of conduction translates into life-saving measures. The conduction system also adapts to autonomic input. Sympathetic nerves accelerate depolarization in pacemaker cells, increasing heart rate and conduction speed. Parasympathetic input via the vagus nerve slows them down, promoting rest. These influences allow the heart to adjust beat by beat to physical or emotional states. For instance, sudden fright triggers a rapid increase in heart rate, preparing the body for action. In contrast, deep relaxation allows the vagus nerve to dominate, slowing the rhythm. Yet the underlying sequence SS node to AV node to bundles to Purkinje fibers remains constant, regardless of tempo. Embryology reveals another layer of wonder. Before nerves develop, the embryonic heart already beats. Its cells possess intrinsic rhythmicity, driven by ion channels and pacemaker currents. Only later does the conduction system specialize, ensuring precise order. This evolutionary safeguard means that life begins with rhythm, innate to the heart itself, independent of external command. Metaphor helps illustrate the system. Imagine a city where lights must turn on in sequence, first street lamps in the outer district, then lamps downtown, finally lamps along the river. If all turned on at once, energy would be wasted and traffic confused. If delayed too long, darkness would linger. The conduction system is the city's electrical grid, ensuring that each region receives its spark at exactly the right time, night after night, without interruption. Disruption of this sequence can be subtle. Athletes may develop extra pathways, such as in Wolff-Parkinson-White syndrome, where impulses bypass the AV node delay and rush prematurely to ventricles. Episodes of rapid rhythm may occur, sometimes dangerous. Treatment may involve ablation of the abnormal pathway, restoring the heart's normal order. Again, the importance of structure in conduction becomes evident. Consider how the electrocardiogram, or ECG, makes this system visible. Electrodes on the skin detect electrical changes as depolarization spreads. The P wave reflects atrial depolarization, the QRS complex ventricular depolarization, and the T wave ventricular repolarization. By analyzing intervals and shapes, clinicians infer conduction speed, rhythm, and integrity. This simple test translates invisible sparks into visible tracings, guiding diagnosis worldwide. Reflect on the marvel: a network of cells, smaller than threads, ensures that billions of beats occur in correct order across a lifetime. Unlike skeletal muscle, which relies on conscious nerve commands, your heart carries its own grid, autonomous and enduring. And yet this sparks the next question. If conduction fibers deliver signals, where does the very first spark arise, and why does the heart entrust this vital duty to a cluster of cells rather than the whole muscle? At the top of the right atrium, just where the superior vena cava opens, lies a small cluster of cells that holds remarkable authority over your entire circulation. This is the sinoatrial node, the natural pacemaker of the heart. Though no larger than a grain of rice, it sets the rhythm for billions of beats across a lifetime. Its cells are unlike ordinary cardiac muscle fibers. They are specialized for automaticity, meaning they can generate electrical impulses spontaneously without any external command. This property ensures that the heart can function independently, beating even when completely disconnected from the brain. The mechanism that grants pacemaker cells their power is called the pacemaker potential. Unlike typical muscle cells, which remain at a stable resting voltage until stimulated, pacemaker cells slowly drift upward toward threshold. This drift results from the funny current, a slow influx of sodium ions, combined with transient calcium entry. Once the threshold is reached, a rapid depolarization occurs, followed by repolarization as potassium exits. Then the cycle repeats again and again. The rhythm of this drift sets the timing of each beat. In most individuals, the intrinsic rate of the sinoatrial node is about 100 impulses per minute, but under resting conditions, parasympathetic influence slows it to 60 to 80 beats per minute. The wave of depolarization spreads across the atria, prompting their contraction. But why does the heart entrust such a vital function to a small node, rather than letting all cells depolarize independently? The answer is coordination. If every cell acted as its own pacemaker, chaos would result, an orchestra of musicians each playing a different tune. By concentrating pacemaker activity in a single site, the heart ensures that all chambers march to one beat. Still, redundancy exists. If the sinoatrial node fails, other sites can assume pacing, though usually at slower rates. The atrioventricular node, Purkinje fibers, or even ventricular cells can generate impulses if required. This layered hierarchy acts as a safeguard against total silence. The sinoatrial node does not act alone. It is under constant modulation by the autonomic nervous system. Sympathetic stimulation accelerates depolarization by increasing calcium entry, raising heart rate during exercise or stress. Parasympathetic stimulation delivered by the vagus nerve increases potassium outflow, slowing depolarization and reducing rate during rest. In this way, the node is like a conductor who keeps tempo but listens to cues from the audience and environment, adjusting speed according to the demands of the moment. Think of a lighthouse perched at the shore. Every few seconds, its beam sweeps across the sea, guiding vessels reliably. The sinoatrial node is such a lighthouse, its light being electrical impulses sweeping across atria. Ships the muscle fibers respond in turn, moving according to the beacon signal. If the main light fails, smaller lamps may take over, less bright and slower, but still functional enough to prevent total darkness. Clinical experiences reveal the fragility of this system. In some individuals, sinoatrial node dysfunction leads to slow rhythms, pauses, or alternating fast and slow beats, a condition known as sick sinus syndrome. Symptoms may include dizziness, fainting, or fatigue. In such cases, an artificial pacemaker can be implanted to provide steady impulses, ensuring reliable rhythm. The device does externally what the node normally accomplishes internally, demonstrating how much life depends on a tiny patch of specialized tissue. Consider the story of a retired teacher who began experiencing sudden spells of lightheadedness during quiet walks. An electrocardiogram revealed long pauses between beats, sometimes several seconds without impulse. The sinoatrial node was failing to fire consistently. After pacemaker implantation, her rhythm stabilized and her symptoms vanished. The case illustrates the dependence of circulation on one small cluster of cells and the relief that technology can bring when nature falters. The sinoatrial node also adapts subtly to circadian rhythms. At night, parasympathetic influence dominates, slowing heart rate. During waking hours, sympathetic activity quickens the pace. This fluctuation aligns cardiac rhythm with the body's rest and activity cycles, ensuring energy is conserved during sleep and mobilized during exertion. Even without conscious awareness, the node integrates environmental and internal signals into steady output. Fetal development provides further perspective. Before the brain's autonomic nerves reach the heart, the sinoatrial node already generates rhythm. In the early embryo, spontaneous depolarization spreads across primitive muscle, sustaining circulation even in miniature form. Over weeks, as structures mature, the sinoatrial node emerges as the dominant pacemaker, assuming the lifelong role it will never relinquish. This origin underscores the intrinsic autonomy of the heart, a feature that ensures survival even before nervous control is established. Pathology can distort this autonomy. In hyperthyroidism, excess thyroid hormone sensitizes pacemaker cells to sympathetic stimulation, producing rapid heart rates that strain circulation. Conversely, in hypothyroidism, pacemaker activity slows, sometimes leading to bradycardia. Electrolyte imbalances, especially in potassium or calcium, can alter depolarization thresholds, pushing the rhythm faster or slower than intended. These disturbances highlight the delicate balance of ions and hormones upon which pacemaker function depends. Modern medicine allows direct visualization of sinoatrial node function through advanced mapping techniques. By placing electrodes along atrial surfaces, clinicians can track impulse origin and spread. When arrhythmias arise from competing foci, these can be ablated, restoring the sinoatrial node to dominance. The ability to map and manipulate such a small structure reflects extraordinary progress, yet also reminds us of how central this node is to the entire system. Reflect on its symbolism. The sinoatrial node is small, silent, unseen, yet it governs the rhythm of your life. It does not contract powerfully like the ventricles, nor does it direct fast flows like the valves, yet without it, order disintegrates. In its persistence, you find the essence of continuity, tiny sparks sustaining great motion. And yet a question remains: if the sinoatrial node initiates each beat, how do those impulses spread so swiftly and evenly through the ventricles, reaching distant fibers at nearly the same moment, ensuring that ejection is powerful and synchronized? When the sinoatrial node releases its spark, it sets the atria into motion, but atrial contraction alone is not enough to move blood throughout the body. For the ventricles to contract in a powerful and coordinated manner, the electrical impulse must descend into the lower chambers with both speed and precision. This task is performed by a set of pathways often called the electrical highways of the heart, the bundle of His, its right and left branches, and the network of Purkinje fibers. These fibers are not ordinary muscle, they are specialized conduits designed to transmit electrical signals faster than any other tissue in the myocardium. The impulse arrives first at the atrioventricular node, where it is deliberately delayed, allowing atria to finish contracting. From there, the signal is handed off to the bundle of His, which pierces the insulating fibrous skeleton of the heart and enters the interventricular septum. Here, the bundle divides into right and left branches. The right bundle travels down the septum toward the right ventricle, while the left bundle splits into fascicles, anterior and posterior, to cover the thicker left ventricle. These branches ensure that both ventricles receive the message simultaneously, despite their structural differences. At the ends of these branches, the Purkinje fibers spread like the roots of a tree into the ventricular walls. They are broad, pale fibers filled with glycogen and adapted for rapid conduction. Their speed of transmission, several times faster than ordinary muscle fibers, ensures that every cell in the ventricles depolarizes nearly at the same moment. The result is a unified, forceful contraction that squeezes blood upward from the apex toward the outflow tracts. Without this synchronized timing, contraction would be fragmented, like a crowd clapping out of rhythm. Imagine water in a garden hose. If pressure is applied at one end, the whole length fills and expels water evenly. But if leaks exist, or if sections activate at different times, the flow is erratic. The Purkinje fibers guarantee that the ventricles behave like a sealed hose, filling with force simultaneously and ejecting with maximal efficiency. The necessity of such coordination becomes clear when it fails. In bundle branch block, one pathway is delayed, and the ventricles no longer depolarize together. Instead, one ventricle lags behind, producing an abnormal QRS complex on the electrocardiogram and a less efficient contraction. If the left bundle is blocked, the powerful left ventricle contracts late, impairing output. In some patients, this dysynchrony contributes to heart failure, and specialized devices called biventricular pacemakers are implanted to restore synchronous activation. This treatment, known as cardiac resynchronization therapy, exemplifies how crucial uniform conduction is for effective pumping. Another disruption is ventricular tachycardia, where abnormal foci in the ventricles override normal conduction. Instead of a smooth upward contraction, the ventricles beat rapidly and inefficiently, sometimes degenerating into ventricular fibrillation, a life-threatening state where muscle quivers without ejecting blood. In such emergencies, defibrillation, an external shock, resets all fibers at once, hoping the sinoatrial node will regain control. Here, the importance of highways becomes evident. When signals wander off-road, the entire circulation collapses. The Purkinje system also shows adaptation to metabolic demands. Because they carry glycogen reserves, these fibers can resist brief interruptions in blood supply better than ordinary muscle. This resilience is vital, for conduction must persist even when circulation falters momentarily, as in strenuous exercise or transient ischemia. Still, prolonged deprivation damages them, and scar tissue from old infarctions may disrupt their paths, creating re-entry circuits that cause chronic arrhythmias. Thus, even specialized resilience has limits. Clinical scenarios highlight these mechanisms. A patient recovering from a heart attack may develop recurrent palpitations. Studies show scar tissue in his septum interrupting bundle pathways. Catheter ablation using controlled burns to eliminate abnormal circuits restores order. His case illustrates how anatomical integrity of conduction highways is indispensable and how modern interventions aim to reconstruct what disease has broken. Beyond pathology, the Purkinje system offers a lesson in efficiency. The rapidity of their conduction reflects the need to contract a large muscle mass almost instantly. If ventricular activation spread cell by cell as in atrial tissue, contraction would be sluggish and uneven. Instead, the highways accelerate the signal, ensuring a sharp, coordinated squeeze. This design mirrors engineering principles where long-distance communication requires fast, insulated cables rather than simple local connections. Consider the metaphor of a city's metro system. Main lines run under the city, dividing into branches that reach every district. Trains depart simultaneously, ensuring passengers across the city arrive together at their destinations. If one branch fails, entire neighborhoods suffer delay, and the city's rhythm falters. In the heart, Purkinje fibers are such trains, departing in waves that ensure all districts the ventricular walls contract in unison. Electrocardiography reveals the fingerprint of these highways. The QRS complex, representing ventricular depolarization, is narrow when conduction is normal, reflecting the rapid spread. When highways are blocked, the QRS widens, a visible sign of delay. Clinicians interpret these signals to diagnose conduction abnormalities, monitor therapy, and predict outcomes. What appears as a few jagged lines on paper is in fact a window into the hidden roads beneath the myocardium. Patients often ask whether conduction is controlled consciously. The answer is no. You do not will your Purkinje fibers to fire. They act independently, driven by pacemaker signals and intrinsic properties. This autonomy ensures survival even when higher systems falter, yet autonomic nerves modulate overall rhythm, increasing or decreasing speed as needed. In this way, highways adjust to traffic demand, but the central command remains electrical rather than voluntary. The elegance of the conduction highways is not in their strength, but in their speed and order. They do not contract with power, yet without them, power could not be expressed efficiently. Their silence is their strength, their invisibility, their guarantee. Reflect on this. The heart's highways demonstrate that speed and synchronization matter as much as force. Their function transforms random sparks into coherent rhythm. But another question waits. If impulses drive muscle to contract together, how is this contraction experienced beyond the chest, at the level of arteries where a wave can be seen and felt with each beat? When your ventricles contract, the movement is not confined to the chest. With each beat, a pressure wave travels outward into the arteries, and this wave can be felt as the pulse beneath your fingertips. The pulse is more than a rhythmic throb. It is the physical manifestation of electrical signals, muscle contraction, valve operation, and arterial compliance working together. By following the pulse, you trace the heartbeat's journey into the periphery, where its rhythm becomes tangible. As blood is ejected from the left ventricle into the aorta, the sudden surge stretches the elastic wall of the vessel. This stretching stores energy, much like air compressing within a balloon. When the ventricle relaxes, the aortic wall recoils, pushing blood onward. The expansion and recoil generate a wave of pressure that travels faster than the blood itself. What you feel at the wrist or neck is not the actual blood passing under your finger at that instant, but the wavefront transmitted through the arterial wall. In large elastic arteries, the wave moves several meters per second, reaching distant sites almost instantly. The character of the pulse reveals much about the state of circulation. A normal pulse is regular, with each beat felt at steady intervals. In arrhythmias such as atrial fibrillation, the pulse becomes irregular, reflecting the chaotic firing of atrial impulses. In conditions of low stroke volume such as shock, the pulse feels weak and thready. Conversely, in aortic regurgitation, the pulse is bounding and forceful, caused by large changes in arterial pressure. Thus, the pulse is both a simple bedside observation and a sophisticated indicator of underlying hemodynamics. Think of the pulse as the echo of a drumbeat in a canyon. The strike occurs at one point, but its reverberation travels far, carrying information about both the drum and the canyon's shape. Similarly, the pulse carries information about the heart and the arteries it traverses. The timing, strength, and contour of this wave encode details about ventricular function, valve integrity, and arterial stiffness. The arterial tree modifies the pulse as it travels. In the aorta, the waveform is broad and rounded. As it moves into muscular arteries, reflections from branch points sharpen the contour, creating a distinct dicrotic notch associated with closure of the aortic valve. In the periphery, the pulse becomes narrower and steeper, reflecting higher resistance and reduced compliance. These transformations mean that the pulse at the radial artery differs subtly from the pulse at the carotid, and skilled examiners can detect clues about vascular health from such differences. Clinical practice underscores the importance of pulse examination. Physicians assess rate, rhythm, volume, character, and symmetry. A rapid, weak pulse suggests shock, whether from blood loss, infection, or cardiac failure. A slow pulse may reflect athletic conditioning or conduction block. Unequal pulses in the two arms may indicate arterial narrowing, such as in subclavian stenosis. Each variation is a signal requiring interpretation, a language of touch refined through centuries of medicine. Beyond physical examination, technology amplifies what the pulse reveals. Arterial pressure waves can be recorded invasively with catheters or non-invasively with tonometry. These tracings show subtle variations invisible to the fingers, allowing measurement of arterial stiffness, reflection waves, and central pressures. Such information predicts cardiovascular risk beyond what routine blood pressure measurements provide. For instance, increased pulse wave velocity indicates stiff arteries, a marker of aging and disease. Consider a patient with long-standing hypertension. His arteries stiffen over decades and the pulse wave travels faster, reflecting loss of elasticity. When examined, his pulse at the wrist feels harsh, rising quickly and falling abruptly. This finding, combined with elevated pressures, warns of increased risk for stroke or heart attack. The story illustrates how the pulse translates microscopic changes in vessel walls into macroscopic signs detectable at the bedside. Another example comes from a young woman presenting with sudden pain in one leg. Examination reveals absent pulse distal to the thigh, suggesting arterial occlusion. Imaging confirms an embolus lodged in the femoral artery. Here, the silence of a missing pulse speaks as loudly as the rhythm of a present one. Restoration of flow through surgery or medication becomes urgent, guided by this simple yet critical observation. The pulse also adapts to activity. During exercise, stroke volume and heart rate rise, producing a stronger, quicker pulse. In fever, metabolism accelerates and heart rate increases, quickening the rhythm. In sleep, parasympathetic influence slows the heart, producing a slower, more regular pulse. These changes reflect the body's capacity to match circulation to demand, a dynamic balance maintained automatically. Cultural history adds another layer. Long before modern tools, physicians of ancient traditions relied on the pulse as a primary diagnostic instrument. In Chinese, Greek, and Indian medicine, pulse qualities were categorized and interpreted, forming systems of knowledge that guided care. While explanations differed, the central insight was shared. The pulse connects the inner life of the body with perception at the surface. Modern cardiology, with its tracings and measurements, continues this lineage with new precision. Imagine the pulse as a signature written by the heart on the canvas of arteries. Each person's signature changes subtly with age, condition, and circumstance. A skilled reader can distinguish strong from weak, steady from irregular, young from old. Yet behind these variations lies the same principle, a wave set in motion by the ventricles, carried outward by elastic walls, arriving faithfully at the periphery. Reflection on the pulse reveals a paradox. It is both ephemeral, vanishing with each beat, and enduring, present throughout life. You can lose awareness of it, yet it never ceases. It represents the bridge between invisible electrical sparks in the chest and palpable evidence in the hand. And so the next question emerges. If the pulse expresses arterial pressure, how are these pressures themselves maintained within safe ranges? And what happens when systemic and pulmonary pressures diverge, creating imbalances that strain the very structure of the heart? The beat of the heart is not only rhythm but also force, and this force is measured as pressure. Pressure propels blood through the arteries, across capillaries, and back through veins. Yet not all circulations demand the same pressure. The systemic circuit delivering blood to the entire body requires high force to overcome distance and resistance. The pulmonary circuit, limited to the lungs, functions at a much lower pressure. The contrast between these two towers of pressure reveals why balance is essential and why imbalance can damage the very organ that generates them. Systemic arterial pressure arises from the left ventricle. At the peak of contraction, systolic pressure reflects the force of ejection. When the ventricle relaxes, diastolic pressure represents the residual force maintained by arterial recoil. Together, these values create the familiar blood pressure measurement. In a healthy adult, systolic pressure is high enough to reach distant tissues, while diastolic pressure ensures continuous flow even between beats. The pulse pressure, or difference between the two, reflects the energy stored in arterial walls. If systemic pressure rises chronically, arteries stiffen, microvessels are damaged, and the left ventricle must thicken to compensate. Hypertension, often silent, thus becomes a major risk for stroke, heart failure, and kidney disease. Pulmonary pressure, by contrast, is gentle. The right ventricle pumps blood only a short distance into vessels designed for exchange, not for endurance. Pulmonary arteries and capillaries are thin-walled and compliant, allowing close contact with alveoli. Pressures here are only a fraction of those in systemic circulation. This protects delicate lung tissue from damage and ensures efficient gas exchange. If pulmonary pressures rise abnormally, as in pulmonary hypertension, the right ventricle is forced to work harder than it was designed to do. Over time, it dilates and weakens, leading to right-sided heart failure. Thus, the lung circuit, though low pressure, becomes fragile when overloaded. The septum between ventricles often shows the strain of imbalance. In pulmonary hypertension, right ventricular pressure pushes the septum leftward, impairing filling of the left ventricle. In systemic hypertension, left ventricular pressure dominates, bulging the septum into the right. These shifts reveal the interdependence of circuits. One side cannot falter without affecting the other, for they share walls, timing, and flow. Think of two towers connected by a bridge. One tower is tall and heavy, the other shorter and lighter. The bridge, the septum, must accommodate both. If the heavy tower grows taller, the bridge leans. If the lighter tower suddenly swells, the bridge bends the other way. Balance between the towers keeps the bridge stable, and balance between systemic and pulmonary pressures keeps the heart aligned. Clinical observation underscores these principles. A patient with long-standing high blood pressure may develop left ventricular hypertrophy, the thickening of muscle required to generate higher force. Initially, this adaptation preserves output. Over years, the ventricle stiffens, diastolic filling suffers, and symptoms of heart failure appear: breathlessness, fatigue, swelling. The high systemic tower has overburdened its pump. Another patient with chronic lung disease gradually develops pulmonary hypertension. The right ventricle enlarges, neck veins distend, ankles swell. The low-pressure tower has risen beyond its design, straining its pump. In both, imbalance between pressures dictates pathology. Measurement of these pressures provides vital clues. Systemic pressure is easily assessed with a cuff, while pulmonary pressure requires catheterization or echocardiographic estimation. Understanding both towers helps clinicians identify where imbalance lies. Treatment often focuses on reducing resistance, relaxing vessels, or supporting ventricular function. While therapies differ, the goal is the same: restoring balance between the two circuits. Reflecting further, pressure is not merely force but information. Arterial baroreceptors in the carotid sinus and aortic arch sense stretch, sending signals to the brainstem. When pressure rises, they trigger reflexes that slow heart rate and dilate vessels. When pressure falls, they prompt acceleration and constriction. These reflexes maintain stability moment by moment. In pulmonary circulation, sensors detect oxygen levels, constricting vessels in poorly ventilated regions to redirect flow. These adjustments exemplify how the body guards against imbalance. Consider also the silent danger of pressure extremes. Hypotension, pressure too low, starves tissues of oxygen. Shock states, whether from blood loss, infection, or pump failure, demonstrate how life depends on maintaining adequate pressure. Hypotension, pressure too high, gradually damages organs without immediate symptoms. Both ends of the spectrum threaten survival, though by different mechanisms. The heart itself is both victim and perpetrator. It creates pressure, and it suffers when pressure is excessive. A case illustrates this duality. An elderly woman arrives with sudden shortness of breath. Echocardiography reveals severe aortic stenosis, where the valve from the left ventricle into the aorta has narrowed. To maintain systemic pressure, the ventricle generates enormous force. Over time, it has thickened, but now it fails under the burden. Her systemic tower has become a prison, trapping her ventricle in excessive work. Surgical replacement of the valve offers relief, lowering the barrier and restoring balance. Another case involves a young man with untreated sleep apnea. Repeated drops in oxygen during sleep cause pulmonary vessels to constrict. Over months, pulmonary pressure rises, and the right ventricle begins to dilate. He wakes with swelling in legs, fatigue, and chest discomfort. His story shows how even a nightly disturbance can gradually elevate the low-pressure tower into dangerous territory. Metaphorically, the body resembles a water supply system with two networks. One network must deliver water uphill to distant villages, requiring high pumps and thick pipes. The other delivers water across a flat plain, with delicate channels for irrigation. If pressure in the uphill network falls, villages go thirsty. If pressure in the plain rises too high, fragile channels rupture. The engineer must balance both. In the same way, the cardiovascular system balances systemic and pulmonary pressures to sustain tissues without harming vessels. Reflect on this. Pressure is the language of the heart's work. Too little, and life fades. Too much, and tissues erode. The two towers, systemic and pulmonary, must stand in proportion, each fulfilling its role. Yet this leads to the next question. If pressures drive blood through vessels, how do tissues at the microscopic level decide who receives more flow, who less, and how is priority managed when resources are limited? As blood leaves the arteries and enters smaller vessels, it reaches the capillaries, the true exchange sites of the body. These microscopic channels, barely wide enough for a red blood cell to squeeze through, form vast networks across every tissue. Here oxygen is released, carbon dioxide collected, nutrients delivered, and wastes removed. Yet the body faces a challenge. The volume of blood is finite, while the demands of tissues constantly change. How does circulation decide who receives priority, ensuring that active tissues are supplied while resting one's weight? The answer lies in the intricate regulation of microcirculation. Capillaries themselves lack smooth muscle, so they cannot control their own flow. Instead, upstream arterioles and precapillary sphincters adjust diameter moment by moment. When muscle contracts during exercise, metabolites such as carbon dioxide, hydrogen ions, and adenosine accumulate. These molecules signal nearby arterioles to dilate, increasing local blood flow. This process, called metabolic autoregulation, ensures that oxygen supply rises exactly where demand has increased. Conversely, when tissues are quiet, sphincters close and flow diminishes, conserving resources for other areas. This local control is layered with systemic regulation. Sympathetic nerves constrict arterioles throughout the body, raising overall resistance and pressure. Yet in active tissues, local metabolic signals override this constriction, maintaining supply where it is most needed. The result is a remarkable balance. Global control maintains systemic pressure, while local signals fine-tune distribution. In this way, blood is not wasted, but allocated with precision. Imagine a city where power stations supply electricity across neighborhoods. During peak hours, traffic lights, hospitals, and factories require more current. Local substations sense demand and allow more flow to those regions. At the same time, the central grid maintains voltage for the entire city. If local circuits were absent, neighborhoods would black out. If central control failed, the whole system would collapse. Microcirculation functions in the same coordinated manner. Capillary exchange itself follows physical laws. Oxygen diffuses from areas of high concentration in blood to lower concentration in tissues. Carbon dioxide diffuses in the opposite direction. Nutrients such as glucose move down concentration gradients or are transported by specific carriers. Water movement depends on hydrostatic pressure, which pushes fluid out. and oncotic pressure generated by plasma proteins, which pulls fluid back in. This balance of forces, known as Starling's law of the capillaries, determines whether fluid leaves or enters at each segment. At the arterial end, pressure favors filtration. At the venous end, absorption dominates. Any disruption of this balance, such as loss of proteins in kidney disease or excessive venous pressure in heart failure, leads to edema, swelling caused by fluid accumulation in tissues. A clinical example illustrates the importance of regulation. A man with uncontrolled diabetes develops damage to small vessels in his eyes. Capillaries leak fluid and proteins, disrupting retinal architecture. Vision blurs, and over time, blindness may occur. Here, microcirculation has been compromised, showing that even the smallest vessels carry weighty consequences. Another example is seen in sepsis, a severe infection that triggers widespread dilation of arterioles. Blood pressure plummets and distribution becomes chaotic. Tissues receive uneven supply despite high cardiac output. The patient develops organ dysfunction, illustrating how breakdown of microvascular control can endanger life. Skeletal muscle demonstrates the power of autoregulation vividly. At rest, only a fraction of its capillaries are open. During exercise, metabolic demand rises sharply, sphincters open widely, and flow increases many-fold. Oxygen delivery keeps pace with consumption, preventing fatigue. If this regulation fails, as in peripheral artery disease where upstream vessels are narrowed, exercise produces pain known as claudication. The muscle's demand cannot be met and ischemia develops. The brain requires even stricter control. Neurons are highly sensitive to oxygen deprivation, tolerating only minutes without supply. Cerebral blood flow is tightly matched to activity, a phenomenon known as neurovascular coupling. When a region of the brain becomes active, local blood flow rises almost instantly. This relationship forms the basis for functional MRI imaging, which detects changes in blood flow as markers of neural activity. Yet if an artery is blocked, as in stroke, autoregulation cannot compensate and neurons die rapidly. The heart itself is also a demanding tissue. Coronary circulation increases when cardiac muscle works harder, responding to metabolites like adenosine. Unlike other tissues, most coronary flow occurs during diastole, when the muscle relaxes and vessels open. If coronary arteries are narrowed by atherosclerosis, flow cannot increase adequately during exertion, leading to angina. Thus, the myocardium illustrates both the power and the limits of microvascular regulation. The kidney presents another fascinating example. It filters enormous volumes of blood, yet must maintain stable flow to function. Specialized autoregulation mechanisms in renal arterioles keep filtration pressure constant despite fluctuations in systemic blood pressure. Without this stability, waste removal and fluid balance would collapse. Diseases that impair renal autoregulation contribute to hypertension and kidney failure, linking microcirculation to systemic health. Even skin participates in dynamic distribution. In cold conditions, arterioles constrict, reducing flow to conserve heat. In heat, vessels dilate, increasing flow to dissipate warmth through radiation and sweating. This thermoregulatory role illustrates how microcirculation serves not only local tissues but the whole organism's survival. Metaphor deepens the picture. Picture a vast irrigation system with canals branching into smaller ditches that feed each field. Gates along the channels open or close depending on the crop's needs. A field in growth receives more water while a fallow field receives less. The farmer maintains overall supply at the reservoir, but the local gates decide distribution. The cardiovascular system mirrors this design, balancing global and local demands through elegant coordination. Reflect on the paradox. Blood is both abundant and limited. The heart pumps liters every minute, yet each drop must be delivered with precision. Too much flow to one region starves another. Too little leaves tissues in distress. The capillary networks, guided by local signals, ensure that supply matches demand. But this raises the next question. Once tissues have received oxygen and nutrients and released wastes, how does blood, now darkened and burdened, find its way back against gravity and distance to the heart that awaits its return? After blood has delivered oxygen and nutrients through capillaries and collected waste products, its task is not complete. It must return to the heart. darkened but essential to be reoxygenated in the lungs and sent out again. This return journey is carried out by the venous system, a vast network of vessels that channels blood back toward the atria. Unlike arteries, veins face low pressures and cannot rely on the strong push of ventricular contraction. Instead, they depend on structural features, surrounding muscles, breathing movements, and one-way valves to ensure progress. Understanding how blood returns illuminates the balance between passive flow and active assistance, and it reveals what happens when this balance falters. The venous system holds the majority of circulating blood at any time, acting as a reservoir that can be mobilized when demand rises. Veins are thinner-walled and more compliant than arteries, meaning they can expand easily to hold large volumes. This compliance is both strength and weakness. It allows temporary storage, but it also means veins cannot generate strong forward pressure on their own. The average venous pressure at the feet while standing may be many times higher than at the chest, simply because of gravity. Without special mechanisms, blood would pool in the legs instead of returning efficiently. Valves embedded in veins are one crucial mechanism. These folds of endothelium, located especially in the limbs, ensure one-way flow. When surrounding skeletal muscles contract, they squeeze veins like pumps, forcing blood upward. Once contraction ends, valves close, preventing backflow. This skeletal muscle pump is activated every time you walk, climb, or even shift position. It transforms everyday movements into propulsion for blood. Without it, circulation would stagnate, particularly in the lower extremities. Breathing provides another aid. With each inspiration, the diaphragm descends and chest volume increases, creating negative pressure in the thoracic cavity. This suction draws venous blood into the chest, while abdominal pressure rises, squeezing blood upward from below. This thoracic pump operates rhythmically with every breath, linking respiratory and circulatory systems. During deep breathing, its effect is magnified, demonstrating how closely life's rhythms are intertwined. The veins of the abdomen illustrate yet another adaptation. Blood from the digestive tract does not return directly to the heart. Instead, it flows through the hepatic portal vein into the liver, where nutrients are processed and toxins detoxified. Only then does it join systemic circulation. This portal system emphasizes that venous return is not merely passive transit, but an opportunity for regulation and filtration. Despite these aids, venous return can falter. In prolonged immobility, such as during long flights or bed rest, skeletal muscle pumps are inactive, and blood stagnates in deep veins. Clots may form, leading to deep vein thrombosis. If a clot detaches, it can travel through veins, pass through the right heart, and lodge in the lungs, causing pulmonary embolism. This life-threatening condition manifests as sudden chest pain, breathlessness, or collapse, requiring urgent medical care. Chronic venous insufficiency is another failure. When valves weaken, blood refluxes and pools, especially in the legs. Varicose veins develop, twisted and distended beneath the skin. Over years, persistent high pressure damages surrounding tissues, causing swelling, discoloration, and even ulcers. Patients may experience aching, heaviness, or itching. Though rarely fatal, this condition reduces quality of life, illustrating the importance of valves in maintaining return flow. Consider a patient scenario. A middle-aged office worker spends long hours sitting. He notices swelling in his ankles by evening, relieved by walking or elevating his legs. Examination reveals varicose veins and valve incompetence. Though not dangerous immediately, his condition demonstrates how lifestyle and posture influence venous return. Movement restores the muscle pump, while immobility encourages stagnation. Another case involves a young woman recovering from surgery. Immobilized in bed, she develops pain and swelling in her calf. Ultrasound confirms deep vein thrombosis. Anticoagulation prevents clot propagation, but the episode underscores how inactivity impedes return. Her story is a reminder that circulation requires both passive channels and active participation. The metaphor of rivers applies here as well. Arteries resemble mountain streams, rushing downward under gravity's pull. Veins resemble rivers flowing uphill toward their source, requiring locks, pumps, and tides to make progress. Every step, every breath, every valve is part of this engineered ascent, ensuring that the cycle completes. Venous return also interacts with the heart through preload, the volume of blood filling ventricles before contraction. Increased venous return stretches ventricular fibers, enhancing force of contraction by the Frank-Starling mechanism. This intrinsic property means the heart adjusts its output to match input. If more blood returns, more is pumped forward. If return decreases, output falls. Thus, the journey back to the heart is not just retrieval, but regulation of cardiac performance itself. During exercise, venous return rises dramatically. Muscle contractions, deeper breaths, and sympathetic constriction of veins all mobilize blood. Cardiac output increases to meet demand. Conversely, standing suddenly from lying down may cause blood to pool in legs temporarily, reducing return and causing dizziness or fainting. Reflexes normally correct this drop by constricting vessels and accelerating heart rate. In disorders of autonomic control, such as postural orthostatic tachycardia syndrome, these corrections fail and symptoms persist. Venous return from the brain also demonstrates special adaptations. Veins in the skull drain into dural sinuses, which channel blood toward the internal jugular veins. Position changes influence this flow, but valves and pressure gradients maintain direction. Increased intracranial pressure can impede venous drainage, leading to headaches or swelling of optic discs. Again, balance between pressures defines health. Reflect on this. The venous system is quiet, low in pressure, often overlooked compared to arteries, yet without its patient work, circulation would halt within minutes. It is a system of return, storage, and regulation, reliant on the cooperation of movement, breathing, and structure. Its failures remind us that even the calmest rivers require guidance. And this reflection leads to the next question. If smooth return depends on valves and vessel walls, what happens when these delicate linings are injured, and why does the blood sometimes clot where it should flow without resistance? The blood you carry is not an inert liquid. It is alive with cells, proteins, and signaling molecules that respond instantly to changes in their environment. To contain this vitality within safe channels, vessels are lined with a single delicate layer of endothelial cells. This endothelium acts as a guardian, sensing forces, releasing signals, and preserving the balance between fluidity and clotting. In health, it ensures that blood flows smoothly. In injury or disease, it can trigger protective clot formation. Yet sometimes the balance falters, and clots form in places where flow should be unobstructed, transforming a safeguard into a threat. The endothelium is remarkable for its subtlety. Each cell is thin and flat, forming a smooth surface that minimizes turbulence. Beyond this passive role, endothelial cells actively secrete substances that regulate tone, permeability, and clotting. Nitric oxide relaxes smooth muscle, widening vessels. Prostacyclin prevents platelet aggregation. Antithrombin molecules on the surface neutralize clotting factors. Together, these create an environment where blood remains liquid as long as the vessel wall is intact. The endothelium is not a mere lining, it is an organ spread across the entire circulatory system. When injury occurs, the balance shifts. Endothelial cells expose underlying collagen, triggering platelets to adhere. These platelets release chemicals that recruit others, forming a plug. Simultaneously, clotting cascades generate fibrin strands that stabilize the clot. This rapid response prevents blood loss, an essential survival mechanism. Once healing progresses, fibrinolysis dissolves the clot, restoring smooth flow. This choreography illustrates how endothelium shifts from guardian of flow to guardian of integrity, always seeking equilibrium. Yet trouble arises when this system activates without external injury. Atherosclerosis provides a vivid example. In this condition, cholesterol and inflammatory cells accumulate beneath endothelium, forming plaques. The surface becomes irregular and inflamed. If a plaque ruptures, blood interprets it as injury, and clotting cascades activate. A thrombus forms, potentially blocking the artery entirely. In the heart, this causes myocardial infarction. In the brain, ischemic stroke. The clot is not protecting against bleeding, but suffocating vital tissues. Another setting is venous stasis. When blood flow slows excessively, as in immobility or venous insufficiency, platelets and clotting factors linger against the vessel wall. The lack of shear stress reduces endothelial production of nitric oxide, tipping the balance toward coagulation. A clot may form silently, deep in the leg veins. If fragments break free, they travel through the venous system and lodge in pulmonary arteries, causing embolism. Here, the clot is not a response to trauma, but to stagnation. Consider a patient example. A middle-aged smoker with high cholesterol develops chest pain while climbing stairs. A coronary artery, narrowed by plaque, ruptures. A thrombus forms suddenly, occluding flow. Myocardial tissue downstream starves of oxygen, and part of the heart begins to die. His survival depends on immediate recognition and treatment. This case underscores how endothelial disruption transforms protective clotting into lethal obstruction. Another case involves a young traveler on a long flight. Hours of immobility slow venous return. A clot forms in her calf vein, unnoticed until she disembarks and feels sudden chest pain. The clot has migrated to her lungs. This pulmonary embolism illustrates how stagnation and clotting combine, endangering even healthy individuals when physiology is strained. The endothelium also responds to inflammation. In sepsis, widespread infection triggers endothelial activation. Vessels become leaky, clotting pathways engage, and disseminated intravascular coagulation may develop, tiny clots forming everywhere, consuming clotting factors, and paradoxically leading to both bleeding and obstruction. This chaotic response reveals the endothelium's dual capacity to defend, but also to contribute to destruction when regulation fails. Think of the endothelium as a diplomat managing borders. In peace, it ensures trade flows smoothly. In crisis, it raises barriers and deploys guards. If the response is proportionate, the nation is protected. If excessive, commerce halts and the system collapses. In circulation, balance between flow and clotting determines survival. Technological advances allow visualization of this process. Angiography shows clots obstructing arteries. Doppler ultrasound reveals thrombi in veins. Biomarkers such as D-dimer indicate fibrin breakdown, signaling recent clot formation. These tools provide windows into the hidden negotiations occurring at the endothelial surface. Prevention and awareness highlight the practical importance. Avoiding prolonged immobility, maintaining vascular health, and recognizing warning signs such as swelling, sudden chest pain, or neurological deficits all relate to protecting endothelial balance. While treatments exist from anticoagulants to stents, the principle remains. Health relies on smooth, uninterrupted flow, maintained by an invisible layer only micrometers thick. Reflect on this paradox. The very system that protects you from bleeding can, under strain or imbalance, become the source of obstruction. The endothelium decides silently, moment by moment, whether blood remains liquid or becomes solid. This decision shapes the course of health and disease. And so another question emerges. If the endothelium senses and signals, adjusting clotting and tone, how does it communicate with other systems, nerves and hormones that also regulate the circulation, and which of these influences takes the lead when demands conflict? The cardiovascular system does not work in isolation. It is under constant regulation by two powerful partners, the nervous system and the endocrine system. Together they maintain stability and adaptability, adjusting heart rate, vessel tone, and blood distribution. Yet their methods differ. Nerves act quickly, transmitting impulses in fractions of a second. Hormones act more slowly, circulating through blood to produce longer-lasting effects. The interplay between these regulators ensures that circulation meets immediate demands while remaining balanced over hours, days, and even years. Nervous control is mediated primarily by the autonomic nervous system, which operates without conscious command. The sympathetic branch accelerates heart rate, strengthens contraction, and constricts vessels. Its neurotransmitter, norepinephrine, binds to receptors on cardiac cells, increasing calcium entry and enhancing force. Its effect is rapid. In moments of stress or exertion, heart rate rises sharply, blood is diverted from skin and gut to muscles, and blood pressure increases. This fight-or-flight response prepares the body for action. The parasympathetic branch, by contrast, slows the heart and promotes calm. Its influence is delivered by the vagus nerve, which releases acetylcholine onto pacemaker cells. This increases potassium efflux, hyperpolarizing the cells and lengthening the time before the next depolarization. Heart rate decreases, energy is conserved, and digestion resumes. The parasympathetic system does not exert strong control over most vessels, but its dominance during rest ensures recovery and balance. Reflexes integrate these signals with remarkable precision. Baroreceptors in the carotid sinus and aortic arch sense pressure changes and send information to the brainstem. A rise in pressure stimulates these receptors, prompting parasympathetic activation and sympathetic inhibition, slowing the heart and dilating vessels. A fall in pressure triggers the opposite. Sympathetic outflow increases, restoring stability. These reflex arcs operate continually, adjusting beat by beat. Without them, simple actions such as standing from a chair could cause collapse from sudden drops in blood pressure. Chemoreceptors add another layer. Located in carotid and aortic bodies, they sense oxygen, carbon dioxide, and pH. Low oxygen or high carbon dioxide stimulates increased breathing and heightens sympathetic activity, ensuring more oxygen delivery. During exercise or respiratory disease, these sensors play a vital role, linking cardiovascular adjustments to respiratory needs. While nerves provide immediacy, hormones provide endurance. Several endocrine systems influence circulation. The adrenal medulla releases epinephrine and norepinephrine during stress, reinforcing sympathetic effects. The renin-angiotensin-aldosterone system controls blood volume and vessel tone. When renal perfusion falls, the kidney releases renin, triggering a cascade that produces angiotensin II, a potent vasoconstrictor. This raises systemic pressure and stimulates aldosterone release, promoting sodium and water retention. Over days, blood volume increases, supporting long-term stability. Another key hormone is antidiuretic hormone, or vasopressin, secreted by the posterior pituitary. It conserves water by reducing renal excretion and also constricts vessels at high levels. In dehydration or blood loss, vasopressin ensures that volume is preserved. Conversely, atrial natriuretic peptide, secreted by atrial cells when stretched, promotes sodium excretion and vasodilation, counteracting excess volume. Together, these hormones fine-tune blood pressure and fluid balance across longer timescales than neural reflexes. The interaction between nerves and hormones can be seen in stress responses. In acute fear, sympathetic nerves accelerate heart rate instantly, while adrenal medulla secretion sustains the response minutes longer. In chronic hypertension, overactive renin-angiotensin signaling elevates pressure despite normal reflexes. Treatments often target this pathway, using medications that block angiotensin or aldosterone to restore balance. Thus, the nervous and endocrine systems collaborate, sometimes reinforcing, sometimes opposing each other. Consider a patient with sudden blood loss after trauma. Baroreceptors sense the drop in pressure within seconds, triggering sympathetic activation. Heart rate rises, vessels constrict, skin becomes pale. Meanwhile, kidneys release renin, leading over hours to increased angiotensin and aldosterone, conserving fluid. If the patient survives the acute phase, endocrine adjustments help restore volume. This coordination illustrates layered defense, immediate rescue by nerves, sustained recovery by hormones. Another scenario involves heart failure. As cardiac output falls, baroreceptors misinterpret this as low pressure and stimulate sympathetic activation. Heart rate and resistance increase, but the failing heart cannot keep up. Simultaneously, renin-angiotensin activity rises, leading to fluid retention and swelling. Initially compensatory, these responses eventually worsen the condition. Treatments often involve suppressing sympathetic and endocrine overdrive, showing how regulatory systems can become maladaptive when chronically activated. The metaphor of governance captures this interplay. Imagine a city ruled by two councils. One acts instantly, dispatching orders to adjust traffic lights and reroute buses within minutes. The other drafts policies, altering infrastructure and water supply over weeks. The first ensures immediate survival of traffic flow, the second ensures long-term sustainability. Both councils must coordinate or the city collapses. The cardiovascular system relies on similar dual governance. Even in daily life, you experience these adjustments. Rising from bed in the morning, nerves increase heart rate to prevent dizziness. Drinking water later, hormones adjust kidney output to preserve balance. During exercise, sympathetic nerves redistribute flow within seconds, while hormones sustain increased output over hours. During sleep, parasympathetic influence slows rhythm, conserving energy. Each transition is seamless, a testament to the integration of these systems. Yet questions remain. which influence is dominant. In short term, nerves lead, in long term, hormones prevail, but overlap exists and at times they may conflict. For instance, sympathetic nerves constrict vessels during stress, while atrial natriuretic peptide released from stretched atria promotes dilation. Resolution depends on context and intensity. The heart and vessels obey the stronger signal, but balance eventually emerges. Reflect on this. Your circulation is guided by both instant messages and lasting decrees, a dialogue between nerve impulses and hormonal signals. They safeguard against sudden collapse and gradual drift alike. But this invites one final question. If the cardiovascular system coordinates so closely with nerves and hormones, how does it interact with other vital systems, lungs, kidneys, brain, to maintain the integrity of the whole body when one component falters? The cardiovascular system is not an isolated machine, pumping in solitude. It is woven into every organ system, exchanging signals and resources in a network of dependence. Blood carries oxygen, nutrients, and hormones, but it also receives instructions from other systems. The lungs, kidneys, and brain in particular form intimate partnerships with the heart and vessels. When these partnerships work, the organism thrives. When one partner falters, the others strain to compensate, and imbalance can lead to disease. Understanding these interconnections reveals how circulation supports life, not as a separate force, but as the centerpiece of an integrated whole. The lungs represent the most obvious link. Without them, the heart's pumping would be meaningless, for the blood would carry no oxygen. Pulmonary circulation is designed not only for gas exchange, but for regulation of blood flow to match ventilation. When a region of lung is poorly ventilated, arterioles constrict, redirecting blood to better oxygenated areas. This ventilation-perfusion matching ensures efficiency. Yet if the lungs are diseased, scarred, inflamed, or obstructed, this matching breaks down. The right ventricle must pump harder against constricted vessels, leading to pulmonary hypertension. Over time, the right heart enlarges and weakens, illustrating how a pulmonary disorder becomes a cardiac one. The kidneys form another critical partnership. They receive about a fifth of cardiac output, filtering blood to regulate fluid balance, electrolytes, and waste removal. In turn, they influence circulation by releasing hormones. Through the renin-angiotensin-aldosterone system, the kidneys adjust blood pressure and volume. If renal perfusion falls, renin release begins a cascade that constricts vessels and retains fluid, raising pressure. This helps in acute settings but can be harmful in chronic disease. Patients with kidney failure often develop hypertension, which then damages vessels further, creating a vicious cycle between kidneys and heart. Treatment often requires addressing both sides of this feedback loop. The brain depends on stable blood flow more than any other organ. Neurons require constant oxygen and glucose, and interruption for even minutes leads to irreversible injury. Autoregulation of cerebral circulation maintains stability despite fluctuations in systemic pressure. Arterioles dilate or constrict in response to local needs, ensuring that active brain regions receive extra supply. During stress, sympathetic drive constricts systemic vessels, but cerebral vessels resist, protecting flow to the brain. When autoregulation fails, as in severe hypotension or hypertension, the brain suffers. Stroke, fainting, or cerebral edema are consequences of imbalance between systemic and local control. Beyond individual partners, the cardiovascular system interacts with the immune system. White blood cells travel within blood, patrolling for infection. When tissues are injured, vessels dilate and become permeable, allowing immune cells to exit. Yet excessive permeability causes swelling, and prolonged inflammation damages vessels. In atherosclerosis, immune cells drive plaque formation within arterial walls, demonstrating how immune and cardiovascular systems intertwine in chronic disease. The endocrine system also plays a role beyond direct hormonal control of vessels. Thyroid hormones increase heart rate and contractility, shaping basal metabolic rate. Cortisol influences vascular responsiveness to catecholamines, modulating stress responses. Insulin affects lipid metabolism, with imbalances contributing to atherosclerosis. Thus, endocrine disorders often manifest as cardiovascular symptoms, revealing the depth of interdependence. Consider an example. A patient with chronic obstructive pulmonary disease struggles to breathe. Over years, low oxygen levels constrict pulmonary vessels, straining the right ventricle. At the same time, reduced activity and systemic inflammation contribute to hypertension and coronary disease. His condition demonstrates how lung pathology extends into cardiovascular dysfunction, weaving a complex web of interactions. Another case involves a young woman with kidney disease. Her damaged nephrons cannot regulate salt balance, leading to persistent hypertension. Her heart thickens, arteries stiffen, and she faces risk of stroke. In her, the kidney-heart connection is not abstract, but a daily struggle. Addressing only one system would be insufficient. Both must be treated together. The integration extends to adaptation. During exercise, lungs increase ventilation, heart rate accelerates, kidneys conserve water, and brain centers adjust autonomic tone. Each system contributes to sustained effort. During sleep, patterns shift, heart rate slows, ventilation decreases, kidneys alter filtration, and the brain regulates circadian rhythms. These coordinated states demonstrate that no system acts alone, all shift together in a dance of physiology. Failure in one system often becomes apparent through cardiovascular symptoms. A failing liver, unable to produce proteins, lowers plasma oncotic pressure, leading to edema. A failing thyroid alters rhythm, producing bradycardia or tachycardia. A failing brainstem disrupts autonomic reflexes, causing unstable pressures. The circulation is both servant and sentinel, expressing disturbances from afar. Think of the body as an orchestra. The heart is percussion, steady and strong, but not meaningful alone. The lungs are woodwinds, the kidneys strings, the brain the conductor. When each plays its part, the music flows. When one falters, the others attempt to adjust, but harmony suffers. Circulation reflects this harmony, its rhythm central yet dependent on others. Technology now allows us to measure these interdependencies with precision. Echocardiography shows how pulmonary hypertension strains the right ventricle. Blood tests reveal kidney hormones influencing pressure. Brain imaging displays flow redistribution during cognitive tasks. Each tool confirms what physiology already teaches. The cardiovascular system is never solitary. Reflect on this truth: the circulation is not only a transport system, but the meeting ground of every organ. Its health reflects the health of the whole. When lungs, kidneys, or brain weaken, the heart shows the strain. When the heart falters, other systems suffer. This reciprocity ensures survival, but also magnifies vulnerability. And with this understanding, you arrive at a final recognition. The cardiovascular system is not a closed chapter, but an open dialogue between body and environment. The question that follows is not how the heart beats alone, but how the entire organism sustains the rhythm of life when any one part threatens to break the pattern. You have now journeyed through the entire cardiovascular system, from the four chambers of the heart to the smallest capillaries, from the silent guardianship of valves to the pulse that can be felt at the wrist. Each section revealed how rhythm, structure, and regulation blend into one continuous flow. The heart does not work in fragments. It lives in a cycle where every contraction is both a beginning and an end, carrying blood outward, drawing it back, and beginning again. The connections we explored showed that the circulation is not merely a pump and pipes, but a living dialogue. The lungs color the blood with oxygen. The kidneys refine its balance, the brain directs reflexes, and vessels themselves speak through their linings. Every beat is shaped by influences near and far, immediate and enduring. This system sustains not just organs, but the sense of being alive, with each cell receiving its share of breath and nourishment. As you reflect, imagine the circulation as a river without source or mouth, always moving, always renewing. It touches every part of the body, yet remains whole, bound together by rhythm. The quiet work of endothelium, the strength of myocardium, the guidance of conduction fibers, and the adjustments of nerves and hormones all merge into one seamless performance. And now the journey pauses. The story of the cardiovascular system does not end, but continues silently in your chest, second by second, hour by hour. With this knowledge, you may rest in awareness of its constancy, a rhythm that began before birth and will accompany you always.